Good evening, everyone. Welcome tonight to the COVID-19 update, Immunocompromised Patients. I'm Melinda Singh Mahal from the Cancer Council WA. I'm the General Practice Project Coordinator. Before we begin, I would like to acknowledge the traditional owners of the land we meet on today, the Noongar Whadjuk people. I'd also like to pay respect to elders past and present and emerging, and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present. A couple of housekeeping points before we get started. We really do encourage you to ask questions. Please save them for the Q&A at the end of the presentations. There's a Q&A function at the bottom of your screen. You can type your questions into there as we go. An online evaluation form will be sent around at tomorrow at the completion of the event, and we encourage you to complete that. It's really great for us to get your feedback and know where we can change things or where we can get new ideas for other presentations. So we'll start tonight with our first speaker, Dr. Daniel Yeoh. Daniel is a paediatric infectious diseases physician at Perth Children's Hospital. He is the medical lead for antimicrobial stewardship and has an interest in infections in immunocompromised children. So Daniel, I'll hand that over to you. Thank you.
So yeah, thanks for having us. As Melinda said, I'm one of the ID physicians here at Perth Children's Hospital, and I've been sort of watching all of this with interest, as I'm sure all of you have been. I'm probably just going to talk a little bit generally about sort of SARS-CoV-2, COVID initially, just as an introduction, then looking specifically at kids. And then I think going on to look at the Kawasaki's like condition that's been described recently in children following infection with SARS-CoV-2. So just as a brief introduction for context, really we all know that sort of coronavirus or SARS-CoV-2, which is the name of the virus, has spread after initially emerging in China in December of last year, and now sort of all countries in the world have essentially been affected. We've been relatively spared here in Australia up to sort of recently, with sort of, I guess, the bulk of recent cases really growing in North America, the US particularly, as well as in Latin America, as you can see. And in Europe, sort of an initial peak that preceded sort of the spread to a lot of the rest of the world after the initial sort of, I guess, spike in China. So really, this is an ongoing issue. And in Australia, as I said, sort of we had our initial wave, if you could call it that, back in March. Across all states, we had a number of cases, predominantly from overseas travellers returning to Australia from Europe, the US and China. And then some onward transmission in the community, but actually most of that could be traced, so not sort of untraced community transmission. But over the last couple of weeks, as you may have seen in the news, Victoria has seen a rapid expansion of community transmission, sort of associated with breaches in hotel quarantine of returned travellers, and then sort of in sort of high density living areas, as well as other family clusters and clusters elsewhere. And so they've gone back into a lockdown of sorts to try and mitigate that. So I guess, what do we know? Just as a brief introduction to pathophysiology, this is an excellent review sort of that was published just earlier this week in JAMA. We know that it's an RNA virus, SARS-CoV-2, related to SARS-CoV-1, which sort of was the etiological agent of the initial SARS pandemic, or I guess outbreak back in 2003. It's also related to for the common circulating coronaviruses, which cause the common colds or the common cold coronaviruses, which obviously don't cause a severe illness. We know that it enters by the ACE2 receptor, importantly. And early on in infection in the lungs, there's an immune response that infects the pneumocytes in the alveoli, and sort of T lymphocytes, as well as macrophages, neutrophils, produce an inflammatory response, which in some individuals is able to clear the virus. But then there's a proportion of individuals who go on to develop severe COVID, which is really characterized by a picture that looks like ARDS. So pulmonary edema, I guess loss of, I guess, integrity of that barrier between the pulmonary vessels and the alveoli, as well as sort of thrombosis and I guess quite an inflammatory state in that space. And we know that of the cases, around 5% will end up needing ICU sort of admission for mechanical ventilation and support. And the fatality rate is probably somewhere around the 1% mark. And certainly that does increase with increasing age, and sort of you rarely see sort of death in children, although we'll talk about the Kawasaki's-like condition later on. So this is another nice sort of pictorial representation of the virus entering via the ACE2 cell with a co-receptor. And really there's several ways how that this coronavirus sort of causes damage. One is direct sort of damage to the cell by the virus. But then also importantly, we know that sort of invasion into the endothelial cells, which happens in severe COVID, so these are the blood vessel cells in the lung, is really important and appears to be actually one of the drivers of severe disease. So sort of leads to coagulopathy, the vascular leakage, and the complications with pulmonary COVID. And also there's this dysregulated immune response with really high levels of inflammatory cytokines, causing sort of, I guess, damage to tissues, not only in the lung, but also sort of in other areas of the body. And we're learning more about this as time goes on. And it really sort of seems like COVID sort of starts off as a respiratory virus, but then sort of affects the endothelial cells, the blood vessels, and then there's effects sort of distally in a lot of the organs of the body. And so I guess what is interesting is that whereas sort of the initial SARS pandemic sort of ended with around sort of a few thousand cases, this new virus has really spread quite efficiently. And what's, I guess, one of the major drivers of that is that often patients are infective before they become sort of symptomatic. And actually, there's a proportion of cases which are mild, that is that they don't end up in hospital needing to go to ICU. So actually sort of you're able to walk around without symptoms, and then initially with sort of early illness without necessarily getting very sick, and that sort of corresponds to the peak transmission period. So there's this pre-symptomatic but infectious period, which has led to sort of, I guess, quite rapid spread around the globe. And that's in contrast with SARS-CoV-1, where really the peak transmission was later on in the illness course, where patients were quite sick and unwell and already in hospital. So isolation was easier and case identification was easier, whereas it's been a lot harder because essentially because of this pre-symptomatic period and mild illness in some patients and sometimes asymptomatic illness, that there may be spread that sort of occurs before we're able to actually identify that people have this. So we know that the viral load peaks early in illness and then sort of degrades after, and usually most transmissions occur within the first week from onset of symptoms, we know that. And so this is, I guess, a representation of what happens is that sort of subject A wakes up, has no symptoms, and then sort of mixes on the train, at work and at home, but then the next day wakes up with a fever and was actually infected for the 24 hours preceding, subsequently gets a positive test. And this highlights, I think, the importance of, I guess, a robust testing system and a public health response to identify cases and then sort of trace the contacts and ensure that the contacts are isolated to prevent onward spread. I guess as an example, in some places in the US, you know, you're lining up for hours to get a test, and the turnaround on that test might be 5 days, by which time, if you are able to trace any contacts, they've likely infected other people. And so sort of the cycle continues. Whereas in Australia, I think we've had a very robust public health response, and that's been one of the strengths that I guess we've had here that's prevented us from, I guess, having the same sort of numbers that we've seen overseas. But definitely this pre-symptomatic spread is a problem and is a reason why that it's sort of, I guess, spread globally. So we know that it does spread pre-symptomatically and also sort of early on in the illness, but how does it spread? And there's been a bit in the news recently about sort of airborne spread and the importance of that. And what that really means is that sort of with respiratory viruses, we know that they spread via sort of expelled droplets. So from the respiratory tract, when you talk, when you sing, when you shout, when you cough, when you sneeze, it produces these droplets, and they're of varying size. There's this sort of, I guess, artificial dichotomy or artificial line that's arbitrary between sort of particles which are smaller, so less than 5 microns, versus particles which are larger, greater than 5 microns. And I think that's really that sort of the smaller particles, if they can contain viable virus, then they sort of float around in the air for much longer and can travel greater distances, whereas the larger droplets tend to drop to the ground or on someone's hands, on surfaces. So if you're sort of more than a couple of meters away from someone who's producing infective droplets, it tends to be a lower risk than sort of, I guess, for viruses where we know that they can be transmitted by airborne transmission. So, for example, measles is a classic one where sort of it's highly infectious and sort of can float around in the air for a long period of time. So the spread tends to be much more rapid. I think based on the epidemiological evidence, although there is sort of lab evidence that aerosols can be produced by people with SARS-CoV-2 and that those aerosols can contain some genetic material and sometimes viable virus, probably the predominant mode of transmission is via droplets. And why is that important? As we said before, although it's sort of not as clear cut or sort of there's probably a spectrum in real life, the larger droplets tend to drop to the ground. So that's where physical distancing is an effective preventative measure. And in the systematic review that they sort of commissioned by the WHO recently, there is sort of evidence, more so from SARS-CoV-1 and sort of MERS-CoV, which was I guess the other severe coronavirus that's emerged in recent years, that actually, the risk of infection drops with increased distancing between people, and that's sort of where this, I guess, sort of 1.5 metre, 2 metre rule has come from, to really sort of get away from people so far that if they're producing droplets which are infective, that they're not actually sort of getting or spreading from person to person. And so that's sort of, I guess, this sort of distancing. The other thing that's been, I guess, prominent more so in Melbourne, where mask wearing is now, I guess, encouraged, particularly in places where you can't physically distance, is sort of what's the use of community masks. So I think one thing that's changed is that early on people were thinking, we shouldn't really be encouraging people to wear masks in the community because actually they're not protective. We know cloth masks don't work as well in terms of protecting individuals compared to surgical masks. But I guess thinking back to the pre-symptomatic spread or asymptomatic spread, where someone without symptoms might be producing these droplets and infecting other people, actually the reason that masks have been mandated in Melbourne and in many other sort of places, and now sort of encouraged in the US as well, is that where you've got lots of community transmission, to try and prevent people from spreading this virus before they're symptomatic, is to sort of make them wear a mask which captures the droplets that they're expelling by talking, by breathing, and protecting other people. So actually it's more about sort of preventing your respiratory droplets from reaching other people in case you're infectious without knowing it, rather than sort of protecting yourself. And I think the thing to highlight is really that masks are part of, I guess, the control strategy, which has multiple components. And I guess the ideal thing is that if you're unwell, to stay away and self-isolate, to try not to mix when there's huge amounts of community transmission as best possible. Hand washing is obviously important for sort of contact transmission, and trying to physically distance where you can, and then masks to be used in indoor settings where you can't physically distance as a component. I think one thing with this diagram, this paper sort of probably doesn't consider I guess the pre-symptomatic spread and the role of masks in sort of mitigating that. So probably there is more efficacy than is illustrated in this diagram, but I think this is really to show that it's one component of many in terms of control. So this is a nice diagram, I guess, in terms of diagnostics, and really PCR is a gold standard diagnosis. We can look at antibody detection because we know most people who have infection, even if it's mild or asymptomatic, will have an IgG response, which can be tested for on serology. And that tends to sort of decrease slightly over time. And I guess the red curve here highlights that the viable virus really is only present for about a week, and that sort of corresponds with the peak infectivity early on and slightly before symptom onset. Just quickly on immunity, I guess we've heard a little bit recently about sort of serological assays where they sort of test the community for antibody response. So there's really two components of effective viral immunity to coronavirus, and one is the B cells, which produce the antibody, and the antibodies bind the virus, stop them from infecting the cells, and then the T cells, which sort of coordinate that, the T helper cells, as well as the cytotoxic T cells, which sort of kill the infected cells once they're infected. And we know that there's both sort of B cell protection, and most patients produce antibody, and where they've tested, actually the majority of patients also will have a T cell response after infection. What we don't really know is how long that immunity lasts for. after infection occurs. But there is some suggestion that the antibody levels are going down over time. But at this stage, there's no confirmed reports of patients catching the virus again after having recovered from an initial sort of infection. But we really don't know how long immunity lasts for. We know from the common cold coronaviruses that immunity does wane for those, which is why you continue to catch the cold every year or two, because although you have some immunity, it wanes over time and you can be reinfected. In contrast with SARS-CoV-1, you can detect sort of immunity up to 3 years, and it seems that people have long-lasting immunity. With SARS-CoV-2, I guess this current coronavirus, seems that people with more severe disease have higher antibody responses, people with milder diseases have less robust antibody responses, but what that means for protection, I don't think we understand at this stage. There are a lot of vaccines in progress, and I'll just highlight a couple. There's different types, sort of, I guess, killed virus, viral vector, nucleic acid and protein based. There's been, I guess, a couple of recent publications, one using an adenovirus vector, where they've incorporated a gene into that expresses the spike protein, which is where the coronavirus protein that binds to the ACE2 receptor and then causes cell infection. And actually, they found that in initial trial, the majority of patients actually developed antibodies, and a lot of these were neutralizing antibodies, so relatively promising. But because they've used an adenovirus vector, actually people who had some immunity to adenovirus, which is the vehicle by which they introduced this SARS-CoV-2 protein, had a less robust response. So that may be a limitation for this type of vaccine. And just as of today, they've published results of an RNA vaccine, which is really just what it says. It takes the RNA or the genetic material of the virus, rather than incorporating it into a cell or killing the actual whole virus. They just take the RNA and then sort of inject it, and then that gets incorporated into host cells. They produce the proteins, and then that induces an immune response. And really, there's not any vaccines licensed out there that use this relatively new technology. So the report from today, just published in New England Journal, sort of shows the results from about 40 patients, healthy, mostly young adults, who were given this RNA vaccine, and the majority, actually all of them, produce neutralizing antibody. So that's promising, but again, we're not really sure sort of whether the presence of neutralizing antibody is actually sort of absolutely protective and how long that protection lasts for. But definitely promising results in the first instance. I guess scaling up and sort of ensuring safety in real world is going to take a period of time, and this particular vaccine has gone to sort of phase 3 trials, and there's also an adenovirus vector vaccine that's gone into phase 3 trials in the US and in China as well. So hopefully we will, I guess, from one of these or a few of these end up with an effective vaccine, but it's still early days. What about herd immunity? There's a lot of talk early on about sort of, I guess, well, why don't we just let this carry on and spread, and then eventually we'll get herd immunity. Sure, there'll be some people who pass away, but then we'll be protected and we can just relax things. I guess aside from the fact that we're not sure whether immunity is long lasting and that people may end up, I guess, losing their immunity, actually even in places where there's been sort of really extensive transmission like the US and Sweden and Europe, the number of people who show sort of antibodies to coronavirus still is sort of less than sort of 10% in most cases, and definitely no more than 20%. And this is a nice diagram from an article in the New York Times, which shows that you probably need 60-70% of people to, I guess, have herd immunity. And that's a level of immunity where if you were just to go about normal life, there wouldn't be ongoing spread of a virus or this particular virus. But actually, if you look even in New York, where sort of they've had lots and lots of infections, lots and lots of deaths, they're not even close to where they need to be. Okay, so clearly, I guess I'm a pediatric sort of infectious disease physician, so very interested in children. So what do we know about children and COVID-19? So we know from other viruses that sort of snotty children tend to sort of be the ones that spread the virus. They spread it with each other and then they go share it with adults. And this is really clear from this diagram of RSV, very common respiratory virus in children. You see the green peaks are the sort of pediatric cases every year, and they're followed by the sort of adult peaks. So these children are sharing the virus amongst themselves during the season, in their daycares, in their schools, in their classrooms, and then sort of passing it on to adults. So I guess there was an initial concern with, I guess, COVID that possibly children might be the super spreaders. But in contrast to RSV and influenza, actually, there was a very small proportion of cases seen in children in China, and similarly in Korea and Italy early on, very small proportions of children, sort of in terms of total number of cases. And also sort of deaths seem to be very uncommon in children. So even when they did get infection, it seems to be milder. And that was sort of reflected, I guess, in the US data as well, that sort of there was a lower number of cases and they tended to have milder disease course compared with adults. And in Australia, this is from a couple of days ago, sort of the government website, even with some increase in numbers of cases in children in the recent Melbourne uptick, still a very small proportion of children in terms of overall numbers of cases, and no deaths thus far, thankfully, in children due to COVID in Australia. And this is one of the early sort of studies out of China that really demonstrated that there's a proportion of children who are asymptomatic, who don't sort of develop symptoms. So there was some fear still that, I guess that really the reason we weren't seeing a huge number of children were that they just had mild infection and they were actually continuing to spread it, but just weren't being picked up because they weren't sick enough to be tested. And that we were really just seeing the tip of the iceberg with children. But there's been a couple of studies since, and the first one was from Iceland, where they screened people in the community, widespread screening, over sort of 880 children sort of screened under the age of 10. And actually they found that despite there being about, 1 to 2% prevalence in the community in this sort of study, that there was really much lower rates when they screened children, just randomly compared with sort of screening older people. And that difference was significant. And when they tested sort of symptomatic people, again, similar results to, I guess, what we've seen elsewhere, that children under 10 particularly seem to be relatively protected. And this has been replicated in a study in Italy, in the municipality of Vo, where they've tested sort of children and sort of young adults and showed that sort of there was a much lower rate of positivity when they tested on 2 occasions, trying to test the entire community where there was significant spread of coronavirus. And further to that, there's been some recent sort of serological assays where they've looked after the peak of infections at the number of patients with antibodies suggesting that they were infected during the peak. And again, it shows that children are somewhat protected compared with older adults. So why is this that children might be, I guess, protected, both in terms of being less likely to catch infection and when they get infection, having less severe disease? We don't really know at the moment, but there are a number of theories. One of them is that actually the ACE2 receptor, which is required for entry of the virus into the cell, as we saw earlier, is expressed less in children. And that was one theory that came out from the SARS-CoV-1 sort of, I guess, spread initially. But actually there's only been limited data and recent data suggesting that sort of there's less of this ACE2 receptor in the nasal epithelium of children compared with older adults, but it's not a huge difference. And so I guess it's possible, but it may not be the complete story. What else could be helpful? We know that children have more flexible, I guess, immature humoral immunity or antibody immunity, and there's some thought that maybe because they're able to produce, I guess, more general antibody, more broadly neutralizing antibody in the first instance, that might put them in sort of, I guess, a better position compared to the adults who have, I guess, less flexible humoral immune systems to neutralize the virus early on. What has been seen recently is that even in people who haven't been infected with the coronavirus, that sometimes a proportion of patients have T cells which can cross-react with coronavirus, and that might protect them from severe disease. It's not been proven, but I guess it's theoretical. And one thought is that because children are sharing the common coronaviruses and that spreads readily in children, that maybe they've got more of this pre-existing T cell cross-reactivity from exposure to the common cold virus. But again, that hasn't been proven. And then thinking back again to the importance of healthy endothelial cells or healthy blood vessels, we know that obesity and sort of high blood pressure and heart disease are risk factors for severe COVID in adults. And we know that generally children have healthier sort of blood vessels, healthier endothelial cells compared with adults. And that may be part of the reason why they're protected from severe disease. This is just an interesting graph that you may have noticed in your practices that you're seeing less sort of bronchiolitis than previous years. And I think because of the lockdown, actually we're seeing sort of record lows of RSV in the state at the moment. And it may also be because people are careful with, I guess, hygiene and the like. So definitely sort of a silver lining to what's happened in recent months. And finally, I'll just talk briefly on PIMS-TS or MISC. So this is a Kawasaki-like disease that's been seen in children following SARS-CoV-2 infection. PIMS-TS is a UK name, which is Pediatric Multi-System Inflammatory Disease temporally associated with SARS-CoV-2, and the US is Multi-System Inflammatory Syndrome in children. It's essentially the same thing, slightly different definitions, but essentially a hyperinflammatory syndrome that sort of occurs following SARS-CoV-2 infection. So this was first recognised in April in the UK, where they seem to sort of be seeing this cluster of children with what looked like Kawasaki's disease, but with sort of severe manifestations, often with shock ending up in ICU, and they've sort of put together a couple of case series since. I guess as an aside, Professor Kawasaki, who first described sort of Kawasaki disease in Japanese children, actually passed away in recent months. I don't think it was from COVID, or at least not confirmed from COVID, but sort of, I guess, ironic in a way. So what is Kawasaki's disease? So this is probably the most common vasculitis that we see in children, although it's not a very common disease. Most of these occur in children under the age of 5, and this is a disease that's characterized by I guess a medium vessel vasculitis with signs of inflammation. So fever for more than 5 days, plus 4 criteria, which are sort of red lips and a strawberry tongue, swelling of the hands and the feet with eventual desquamation, a polymorphous rash, tender cervical lymphadenopathy of greater than 1.5 centimetres, and bilateral sort of conjunctival injection, which is not suppurative, so no pus, but sort of conjunctival injection. So it's really a clinical diagnosis. No one really knows what the cause is. There's been some thought that it might be triggered by an infection. We know that there's a predilection for children of Asian descent to have, I guess, Kawasaki's, and obviously first described in Japan. The highest rates in the world are described in Japan, and even in sort of the Western Australian series that was published a few years ago, there's a predominance of Asian children. So over half the cases within WA over the last sort of few years have been in pediatric patients. So this is sort of from the American Heart Association guidelines. So the strawberry tongue, cracked lips, the red eyes, the polymorphous rash, swollen feet, large cervical lymphadenopathy. And why is this important? We know that a complication that occurs in about a quarter of children is coronary artery aneurysm, which can actually sort of lead to obstruction or sort of sequelae down the track. Can be treated by IVIG, intravenous immunoglobulin, which puts an end to the sort of inflammation, ceases the fever in most cases, and reduces the risk of coronary artery aneurysm from 25% down to 4%. And it's really one of those diagnoses that you see relatively rarely, but even as I guess generalists, and particularly I guess as paediatricians, we need to be aware of this. And we had quite a tragic case a few years ago that went through the coroner's court, where there was this young child who was turned away from hospital, turned away from the GP on a number of occasions, who had subsequently sort of passed away and wasn't flagged to have Kawasaki's until sort of, I guess, after the fact. And so this was really sort of a tragedy which was possibly avoidable. And I guess it's just important to be aware that Kawasaki's in the child with prolonged fever, particularly with some of these atypical features, with some of these other features, Kawasaki should always be a consideration in these kids. So just back to the PIMS-TS multi-system inflammatory syndrome. In Italy, this nicely sort of illustrates that they saw a peak of, I guess, Kawasaki-like presentations in the second quarter of 2020. And looking at the second graph, this is sort of the number of SARS-CoV-2 cases which sort of peaked earlier, and then see these asterisks here later, seems to follow on from that, suggesting that it might be more to do with an immune response to infection with children who were infected earlier, who then developed sort of this hyperinflammatory response. And there's been, I guess, a number of theories from France, from the UK and the US, sort of over 100 patients in the US series. And from this, we know that it seems that sort of, as opposed to Kawasaki's, where Asian sort of children are more affected, tends to be children with African background who tend to be overrepresented in these cases. They're older than the Kawasaki's children, so tend to be sort of around 9 or 10 years of age, as opposed to most of the cases of Kawasaki's being under 5 years. There's more GI symptoms. They're more likely to get shock and end up needing sort of inotropic support, ICU admission, and sometimes ECMO. There's a lot more inflammation, so the CRP, ferritin, and fibrinogen levels are much higher, and there's more evidence of myocarditis, so the troponin's elevated and markedly elevated in some patients, but at least elevated in the vast majority of patients. Promisingly, when we use treatments similar to sort of what we use for Kawasaki's disease, that is sort of IVIG plus or minus steroids, sometimes some other immunomodulatory agents, these children seem to get better And mortality is actually relatively low in these series, only about 2%, but still quite a severe illness needing quite I guess, extensive ICU support. And this is just, I guess, pictorial representation showing that sort of gastrointestinal symptoms are predominant. And actually respiratory symptoms are there, but not really the predominant feature. Maybe around half of patients have respiratory symptoms. So it tends to be more of an immune sort of reaction. And as we can see, similar to that Italian data, the peak of coronavirus cases, which is a yellow line, seems to precede the peak of cases of this multi-system inflammatory syndrome, which I think suggests that it's driven by the immune response and maybe similar to adult COVID or severe COVID, a maladaptive or an inappropriate immune response to SARS-CoV-2. And it's different from Kawasaki's disease in terms of the age profile, as well as sort of high inflammation and high levels of cardiac inflammation. So older children, more GI symptoms, but some overlap with Kawasaki's disease, and coronary artery aneurysms seem to happen in about a quarter of these patients as well, looking at the overall numbers. So just to summarise, we know that sort of severe COVID-19 does happen, ICU support about 5%, mortality of about 1%, looks like ARDS, and there's also these sort of manifestations outside of the lung. And that, I think, inappropriate inflammation and endothelial cell dysfunction seem to be important drivers of severe disease. The pre-symptomatic spread is important, and that's why, I guess, trying to have robust ways to identify cases and contact trace in a rapid turnaround time, as well as maintaining some levels of physical distancing and possibly the use of community masks and appropriate hand hygiene are all important components of limiting spread. We're not really sure about the duration of immune response, and herd immunity probably isn't going to be attainable without sort of a vaccine, but there are several vaccines in development with some promising early results, but they're a long way off from being sort of rolled out extensively. Children appear to be less susceptible, and there's several possible mechanisms for this, and understanding this might help us understand sort of why certain adults get more unwell with COVID-19. And there is this sort of, I guess, rare but very severe complication of SARS-CoV-2 infection in children that looks a bit like Kawasaki's disease, but tends to happen in older children, but does respond to sort of the Kawasaki's disease treatments, at least sort of in these case series, and death is thankfully rare in that scenario.
Thank you, Daniel. We do have a couple of questions which we'll put to you at the end. Next, I'd like to introduce to you Professor Michael Millward. Professor Millward is the Foundation Chair of Clinical Cancer Research at the University of Western Australia, and he is a consultant medical oncologist at Sir Charles Gardner Hospital and Linear Clinical Research. He has a strong track record in delivering clinical trial outcomes and has extensive clinical and research interests in lung cancer and melanoma. Thank you, Michael.
Well, good evening, everybody, and I'm going to talk to you about COVID-19 from the point of view of cancer patients and oncologists. I'm going to use the term COVID-19 to refer to the disease itself, the virus itself, the pandemic situation itself, and the sort of response that we have. So I hope when I use the term COVID-19, it will be clear what context I'm using it in. Right. I'm sorry, my screen has frozen. Just hold on. Okay. The things I'm going to talk about, the risk of COVID-19 infection in cancer patients. I'm going to talk about the impact of the pandemic on cancer patients. I'm going to talk about the impact on cancer care. If I have time, I might say a word or two about clinical trials, and preface it all by saying we're obviously in a very lucky situation here in Western Australia. When I gave a variation of this talk to oncologists a while ago, it was all very unclear, and I think we were all very scared. Whereas now we have a perspective, a lot more information, And as I say, we're in a very fortunate situation. So what is the risk of COVID-19 infection in cancer patients, and which particular cancer patients are at risk? Now, clearly, the risk of getting COVID-19 infection is primarily related to the transmission in that community. And the data we have has come from countries and places with very high levels of transmission, such as initially China, then New York, and now centres in Europe and elsewhere. And it was recognised in the early days of the COVID-19 pandemic in Wuhan that there were increasing cases in cancer patients, and cancer patients did seem to be at particular risk. And so this was reported early on and subsequently published from Wuhan, but a fairly small number of patients, only 105, but with institutional controls, a fair number without cancer, but with COVID-19 at the same institution. And when you collect data for these sort of reports, there's always the sort of dichotomy between wanting to report things quickly and get information out there. At the same time, you need lots of data, and you need to have appropriate controls to inform the situation. One thing that was reported and is frequent in Chinese reports about cancer and COVID is a very high percentage of their cancer patients actually acquire COVID-19 while they're in hospital. And this was almost certainly from the early days because of unrecognized transmission from patients to patients and patients to staff. So this is the publication of theirs. I've sort of blown it up to make it a little easier to read, but they've used 4 measures of severity, death, invasive ventilation, ICU admission, and composites of severe respiratory function. The first one at the top left, you can see the death rate, and all these severity measures are significantly higher in the cancer patients than in the non-cancer patients. The graphs on the right are time, and you can see the time to death is more rapid in the cancer patients as well as at a higher level. C and D refer to particular types of cancer, and the types of cancer that had the highest risk in this series were hematologic cancers in purple and lung cancers in red. In E and F, this refers to patients in green with metastatic cancer. Orange refers to patients with cancer but without metastatic disease, and blue is no cancer. And you can see the risk is overwhelmingly concentrated in patients with metastatic disease. G and H are very interesting, and I've never seen this analysis repeated in any of the subsequent studies. Red is patients with lung cancer. Orange is patients with cancer that's metastatic but do not have lung metastases. And green is patients with cancer with metastases to the lungs. And you can see the patients with lung metastases and lung cancer are very similar, whereas patients with metastases to other sites are not. And this suggests, at least to me, that there's something about cancer in the lung and metastatic disease in the lung environment that is somehow perhaps altering the normal lung function or the normal lung immunology that's contributing to these poorer outcomes. The final graph refers to the most recent treatments received. And in this series, the trend was, although not universal on the markers of severity, that patients who had had surgery and immunotherapy as their most recent treatments seemed at particular risk. However, the numbers in each of these subgroups, when you slice and dice, is pretty small. So that needs a lot of verification. And by and large, as we'll see, it hasn't been borne out. This is the first report from New York, and they looked at the death rate in patients with from COVID-19 in cancer patients, controlled patients without cancer from their own institution, and data from New York City as a whole. And you can see the death rate for cancer patients who got COVID was 28%. Control groups in their institution was 14%, and New York City as a whole was 6%. These institutions that contributed to this data were largely from poorer socioeconomic areas with a lot of patients from minorities and with comorbidities. If you look at the age distribution, then the deaths are predominantly in older cancer patients, although if you look at the relative risks, the relative risk is higher in younger cancer patients. And this is because, as we've heard, it's very, very rare for younger patients to actually die of COVID. So if they happen to be a young cancer patient, then the control group will be very low. We now have studies on much larger populations and multinational and multi-institutional cohorts have been put together. This is a US-based cohort, although there are some patients from outside the US. I'm going to show you some data from their presentations last month, although both have now subsequently been published. And they collected over 1,000 patients, and you can see the speed with which they collected patients. They collected 1,000 cancer patients with COVID in less than a month, corresponding to the first peak of the US pandemic. They excluded a number of patients, patients who didn't have laboratory confirmed COVID. And the death rate was 13%. And you can see the other percentages are also high for various outcomes relating to severity and the need for hospitalization. There were some features in cancer patients that were associated with a higher death rate. Men, older patients, former smokers, patients who were of poorer performance status, which means they had more symptoms from their cancer, and patients whose cancer was progressing. And as you can see, patients who were treated with hydroxychloroquine and azithromycin also had a significantly higher mortality. There were some factors that did not reach significance in these large numbers. Non-Hispanic, i.e. African American, obesity, hematologic malignancy, recent chemotherapy, or recent other cancer treatment, including immunotherapy. So in this large cohort, the risk factors were primarily not related to the cancer itself, but were related to whether the cancer was behaving aggressively or the patients had other general risk factors, such as increasing age and male sex, which I've summarized there. Now, this next data set is much more international, but it's restricted to patients with predominantly lung cancer. And this is interesting for me because I deal a lot in lung cancer, but also because lung cancer had been identified from China as a cancer type of particular risk. So data from many sources around the world. They have many more patients. This is their initial presentation, which has about 550. You can see they're predominantly current and former smokers, reasonably good performance status, and reasonably balanced. There are three groups here: those who had COVID and recovered, those who had COVID and died, and those where the situation was still ongoing, neither recovered nor died. All of these factors are fairly balanced. They did, however, include a small number of patients who had COVID diagnosed on the basis of radiology or clinical symptoms without PCR confirmation. And I think most studies now would not include those patients. They'd insist on PCR diagnosis. And blue, remember, the patients who died. So there are some things that are associated, particularly hypertension, chronic obstructive pulmonary disease, diabetes, and vascular disease. And these are all things that are common in these older lung cancer patients. They did not see that patients had a particularly increased risk with immune treatments, targeted treatments used for lung cancer, but a slightly higher death rate in patients who'd received recent chemotherapy. And these show some of the time to event and absolute curves related to age, comorbidity, and performance status related to their cancer. And to make the point, patients on steroids did worse, patients receiving anticoagulation did a bit worse, and this reflects the data on prior anti-cancer treatment. On a multivariate analysis, the things that stand out are age, poorer performance status, so more symptoms from their cancer, and marginally steroids and the type of prior anti-cancer treatment. The only study that I'm aware of that has reported that cancer patients do not do worse is this presentation. It's not yet been published, from the major cancer center in Paris. And they had a fairly small number, but a substantially higher rate of patients who were either in remission, had localized cancer, or had curative therapy. So far fewer with more advanced cancer. That's their quote. "We have not found evidence that COVID-19 is more lethal or aggressive in cancer patients. Their death rate in their institution was similar to both Paris and France as a whole at the time." However, that's, I think, an outlier and doesn't reflect the larger series and series from many other countries. So what do I think? Cancer patients are at higher risk of COVID-19, and they're at higher risk of severe disease and death. Some cancer patients and some disease characteristics are at higher risk than others. The data, and there's more which I haven't shown you, is reasonably consistent but has limitations. It's been collected largely retrospectively. There are a lack of appropriate controls in some studies. Some studies are reporting small numbers, and many of these are reporting data collected over a short period of time at the beginning or the height of the pandemic. One thing that's not been addressed in any of the publications is whether the poor outcomes in cancer patients are related to them not receiving appropriate care, either because of triage or because of advanced care directives. But clearly this could impact on outcomes. There is some limited data, which I haven't reviewed, but you'll have to take my word for it, that says that cancer patients who recover from COVID take longer, they have longer hospital stays, they remain PCR positive longer, and they have lower levels of subsequent antibodies. But as we've heard, what exactly that means is unclear. So there are two things that we need to do in terms of protecting the cancer patient. If cancer patients are at particular risk, we need to prevent them from catching COVID by such means as are possible. And these are just some of the things that obviously have been used and are still being used. Both isolation, the use of masks, recommending flu vaccines, shifting care to telehealth, treating patients at home, patient flow at treatment centres being set up to minimise contact between patients and other patients and staff, making sure cancer patients are as discreet as possible from the general hospital population, limiting visitors for cancer inpatients, and what has been termed screening, which has been a mixture of both asking patients symptoms, monitoring temperatures, and even in some places, although not here, recommending patients be tested for the presence of COVID prior to embarking on anti-cancer treatment. But there's a wider need to protect cancer patients, not just from catching COVID, but from receiving suboptimal and poor cancer care. So many of these things were introduced, many have now been relaxed. So to minimise the risk of staff shortages, changing of work patterns, dividing treatment units into teams, limiting cross-hospital work, and obviously conducting meetings virtually. There have been a lot of changes made to cancer treatments, including changing some plans, reducing radiation courses to smaller numbers of treatments, preferring oral rather than intravenous therapy, reducing long-term maintenance therapy for cancer, trying to give treatment less frequently, and give patients treatment holidays. And there's also been, to some extent, the redeployment of the workforce from those research and academics to clinical service. And I saw the other day at the UK pandemic in April, up to 20% of physicians were actually off work because they were isolated, because they had symptoms that were being investigated, or because they were required to act as carers for others. Many guidelines have been published to what they term prioritise, but I like to think of as deprioritising access to treatment. The first two are Australian, US, European, UK, French. Virtually every country has written variations on the same guidelines about how we should try and take care of cancer patients during the pandemic. However, the emphasis has been very much on the immediate severe short-term situation. What hasn't really been considered is whether there will be long-term disruption to normal services and activities. But if there is, then the consequences will be potentially severe. Because poor care is not just going to relate to things like inability to get into hospital, workforce members getting sick, but there will be longer system and societal changes. The slowdown and cessation of clinical trials and cancer research, the closure of screening services, the limitations on travel affecting education and training of specialists, the impact on cancer NGOs, and, which we're already seeing, a lesser thought of cancer as a health priority. What is very clear that has been reported from Australia and overseas is that the COVID pandemic has led and continues to lead to a reduction in new cancer diagnoses. And these cancer diagnoses won't go away. What will happen is these patients will present in the future in a more advanced disease form that will almost certainly increase mortality. This is data from the Netherlands and related to the changes in cancer diagnoses from corresponding periods the previous year. You can see in blue all sites as soon as the pandemic started, which is the green, the diagnoses went down, They then came up a bit. As soon as there was strict social distancing, they went down. And then when there was a public awareness campaign about the need for screening and presentation with symptoms, it went up again. Red is skin cancer, which is principally melanoma because BCCs were excluded. And you can see the difference there was even more marked and slow to resolve. This is a bit small, I'm sorry, but you can see the reductions were particularly severe in breast cancer, which is dependent on screening, urologic cancer, perhaps to the same extent, lesser so for those that present symptomatically, such as gynecologic cancers, reduction particularly for GI cancers, where there's both screening and need of access to endoscopies. This is a US analysis that is looking at a model to try and predict the excess mortality from breast and colorectal cancer as a result of the pandemic. They have made the assumption that there will be 6 months of what they term moderate disruption to screening, investigations, and surgery. I'm not clear exactly what they mean by moderate, and I'm not sure the pandemic is only going to last 6 months. But if you make those assumptions, these are cumulative, by the year 2030, there will be roughly 10,000 excess deaths from breast and colorectal cancer, largely in the years up to 2026. So these are cumulative, so you can see it rises very quickly up to 2026 and then flattens out. What we do know, at the start of the US pandemic, there was a substantial reduction in new diagnoses, that should say, of colorectal cancer, more than 50% reduction in surgeries for colorectal cancer, and a 90% reduction in colonoscopies. What have we seen in Australia? Well, we've seen statements from the AMA expressing concern about patients missing out on cancer diagnoses. We've seen reports from the major Sydney and Melbourne cancer centres of a 20% reduction in new referrals with cancer. The Royal College of Pathologists have reported a 40% reduction in cancer tests, including 70% plus fall in cervical cancer screening and 56% less biopsies. Significant reported drop in breast cancer surgeries and notifications of breast cancer to the Victorian Cancer Registry. I looked at the referrals to the WA Melanoma Advisory Service, and you can see there that when we were having our social restrictions and lockdown, that number fell very, very sharply. So we're expecting a substantial presentation of patients later on as a result of this. So what we have to do, we have to assure patients that it's time to resume regular screening, regular assessments, regular GP visits. Visiting GPs and hospitals is safe. Delays in diagnosis and treatment can and will be fatal, and cancer patients will not be deprioritized. In terms of clinical trials and clinical research, we've had some major changes made. I've sort of summarized them there from our own practice and from the literature. These are from predominantly US literature, and these are the sites or percentage of sites reporting these type of changes. There are positive changes that have been made, both in research and clinical practice, some of which will continue, such as remote and at-home treatment, telehealth, more flexible work practices. From the trials point of view, remote consenting, faster approval, rapid opening of trials, and flexible trial designs, and the need to consider SOPs to cover things like pandemics, which perhaps not surprisingly, nobody had really thought would ever occur. This is from the global lung cancer study that I presented earlier. This all started with one Italian oncologist having the idea to do it on the 15th of March, 3 days to create a database, 2 more days to get ethics committee approval, and you can see within a month, 300 patients in 24 countries, and you could already 1 publication. So speed can be done. Speed, what we used to think would take months and months and months, can be done much quicker. So far in Australia, we've seen roughly 100 to 110 people die of COVID-19. This is a disastrous pandemic that's had major implications for patients, for ourselves, and for the community. But in perspective, in Australia, 130 to 140 patients die of cancer every day, every single day. Cancer is a public health emergency as well, and we mustn't let the pandemic put us in a position where cancer patients are at risk, or future cancer patients are at higher risk of death. Thank you, and I'm happy to take some questions.
Thank you, Michael. That was fantastic. We do have a few questions. I'll just scroll up to the top. So we have a question first, I think, for Daniel. Masks protect the spread of COVID-19, but do they act as protection from getting the virus?
It's a good question. I think the evidence for sort of, I guess, community masks for protecting the individual is probably not as sort of, I guess, established. I think the important sort of role of masks is really for that prevention of, I guess, spreading from the person wearing the mask. There's probably some limited protection, but in the trials that they've done comparing cloth masks with surgical masks in the hospital setting, cloth masks aren't as effective at preventing sort of a person breathing in infected droplets. So probably the widespread use is more to prevent sort of people breathing out droplets rather than protecting the individual.
Thank you. Another question, does the patient who's taking medications have a worse or better prognosis against COVID-19? And I think, Michael, you might have touched on that in your presentation.
Yes, I think clearly for cancer patients, the data would suggest that patients who are on chemotherapy are at a higher risk than other cancer patients, and probably patients taking immunotherapy are not at substantially higher risk, although that's a very hot area at the moment, and that data continues to evolve. There's even some suggestion that the immune checkpoint inhibitors used for cancer therapy can both protect patients from COVID-19, but if they get it more severely because that it enhances the sort of inflammatory syndrome. But that's all unclear at the moment, so we're not restricting treatment that way. As far as general drugs, the only thing that I've seen that people have been concerned about are ACE inhibitors, and I think the data now is that patients on those aren't at higher risk.
Okay, thank you. And perhaps this can be for both of you. How much value do we put on the small cohort studies? Daniel, perhaps you'd like to answer that one.
I guess maybe if that's in reference to, I guess, the pediatric studies on PIMS TS or the Kawasaki's like disease. I mean, I think they're relatively small in their own right. I mean, the US ones, they published a large, but now I guess sort of if you put all together all the cases, there's probably over 1,000 described in the literature. So I think, and the pattern is similar in those studies, and that is that sort of this is likely an entity that is characterized by a lot of inflammation driven by an immune response to coronavirus, and that sort of the population affected are older than those with Kawasaki's, are in sort of more predominantly children with African background, and that they can get very sick very quickly, but promisingly sort of IVIG and steroids seem to sort of lead to response in the majority. So I think the pattern across, I guess, the relatively, I guess, broad sort of from a number of different locations seems to suggest that this is a new entity which is separate from Kawasaki's.
Okay, thank you. And we have a last question. What regime do you recommend for Fluvax and Pneumovax? 13 and 23 in brackets.
Oh gosh. I think from a pediatric point of view, we're still recommending sort of vaccination. And I think it's funded in WA for under 10-year-olds this year. Certainly we've had a high uptake in our hospital population and dry immunisation centre here. And for children who are younger, I think over 6 months of age obviously is the age limit, to have 2 doses in the first year they're receiving that vaccination. So about a month apart. So I think we're still recommending influenza vaccination. I think similar actually to the RSV graph that I showed earlier, we're seeing less influenza at this stage, definitely compared with last year and probably compared with previous years. But there is that ongoing risk, and that is something that we do have an effective, albeit partially effective vaccine for.
Okay, thank you. That's all for questions, unless either of you would like to add anything else.
I could just make a point about cancer patients and sort of vaccinations. The recommendations that we have are that cancer patients are at risk, obviously, of influenza and other vaccine preventable illnesses. And we always encourage cancer patients to have flu vaccinations and, if indicated, pneumococcal vaccinations. There is obviously some data that cancer patients produce a less robust response to vaccinations, but that's not a reason not to give it. So we're not changing from that point of view. We can hope, but we'll see, that when we get our COVID vaccine, that it will be effective for cancer patients as well.
That would be terrific. Well, I think that's it for the questions. So thank you, Daniel and Michael, tonight for your thorough presentations on the impact of COVID-19 on immunocompromised patients. I'm sure everyone has found some valuable points to take back to their practice. Thanks for your time this evening.